please?
Yes, sir.
Nishanth Madhivanan is the director of MNI Hospital. He's an extremely versatile cataract surgeon and a refractive surgeon.
Good evening, everyone. Thank you, Ramesh sir, for giving this opportunity for being a part of this amazing team where we have always spoken. And to all the listeners, if you all have actually listened to Dr. Atik talking about how to select a patient, and if you had listened to Dr. Ramesh sir talking about what are all the formulas to be put in, and if you'd have heard or even tried to follow a bit of Dr. Arul sir's surgical excellence, I'm sure that I will not have anything else to talk about for now. And Dr. Jayanthan's in special situations have actually covered all the other modalities as well. If you have missed all these talks, I'm just going to give you some tips and hints where you can try to make sure that you rectify and get a good post-operative outcome. So where are all the surprises which can come? One, you will have it preoperative in terms of inaccurate preoperative measurements, inaccurate marking of the cornea and the posterior corneal curvature, which is not taken into. Intraoperatively, the placement of IOL, the shifting of axis and retained viscoelastic in the bag, and postoperatively is the main rotation of the lens by itself. So we all know that a misalignment of 10 degrees will actually cause around 30% loss in an effective power. And a misalignment of 30 degrees is a complete re-rotation of the lens where 100% loss of effective power will be there. And for higher power toric IOLs, that is like T9, if it is off by 10 degrees, there'll be a leverage of 1.3 diopters. So even in cases of T2 or T3 lenses, a 10-degree misalignment might be okay, but not in higher astigmatic cases. So what are all the problems? The miscalculation of refractive magnitude is the posterior corneal astigmatism, the pseudo-astigmatism because of the dry eye, the pterygium, and the dystrophies, which are the main causes, and a lot of inflammation of the eye as well. And if a miscalculation of the axial length where the effective lens position of the eye is not perfectly in the center, and non-corneal astigmatism, that is like an eye altered if the lens is completely not in the bag, one of the haptics is either in the sulcus, or there is any other macular problems. So how do you evaluate? So the main thing first you have to do post-operatively when you have a surprise is always refract the patient, look for a spherical and a cylinder correction. If you have a spherical correction, there might be some miscalculation with the IOL power calculation. If there is a cylindrical correction, there is also a possibility that along with the miscalculation of the prerequisites, you could have also had an IOL tilt. And the diagnosis by the biometry, the topography, and the OCT and eye trace is very important, because OCT at the normal K value, like what Dr. Atik said before, it was only K value, but OCT guided value of an IOL power calculation is what is the best, which is now, because it takes into the axial length from the fovea of the macula. And ocular surface examination of patient with some amount of inflammation, dry eyes should be treated first, because they can also cause some amount of irregularities as well. What are all the choice of correction when you have a problem? First, I would actually say that if the patient has done both the eyes vision, if OU vision, the patient doesn't have any problem and you are only able to see some amount of torus changes, if the patient is comfortable, always leave the patient alone. That's the best choice. If the patient starts complaining, yes, you have an option of either spectacles or contact lens. And then IOL rotation, as Dr. Arul sir said, I've started using it my hospital as well. Always half an hour after the procedure, look at the patient under the slit lamp. The pupils will be dilated. So you do have the markings as well. You can rotate your slit lamp according to the marking, and always make sure that you check. Because in that half an hour or 45 minutes time, if the lens is not rotated, it might not rotate after 3 days or a week's time. So the first half an hour is the most important and the crucial time. And if there is a rotation when you feel like you want to rotate, you can always go back to the operation theater saying that a slight correction is required topically as well, instead of waiting for 3 days to a week's time and then retaking the patient to the operation theater, which might cause a little bit of scare for the patient. And in high degrees of misalignment between the spherical and cylinder calculation, after around a week or 15 days, you can take a decision whether you want to exchange the IOL as well. Laser vision correction is also an option which is available for my side, I will say that if it is less than 3 months, a surface ablation can be done. If after 3 months or 6 months, if you feel that there is some amount of residual correction, yes, you can try to do a flap procedure with caution. And relaxing incisions should be accurate. It will be best if we can do femto assisted relaxing incisions. So what will be the management protocol? Start by evaluating the spherical equivalent. You find an error in the spherical equivalent, you have the laser vision correction or the lens exchange like I told you. What if it is a plano? So you have to determine the prerequisite cause. You have to go back and see what are all the other possibilities. If the IOL position is on axis, and if you still feel that the patient is having some amount of problem with the cylinder, please, you have to show the eye tracy. Yes, there are other modalities like Sirius, which also show some calculation, but eye trace actually, even if you don't have it, I would say that you have to refer it to a center which has, because if you're not sure that the alignment is perfect and your calculation is perfect, and still the patient has, yes, eye trace shows some amount of changes. If at all, you have to make the rotation. And if it is off axis, the only thing is rotate. There is actually a website called astigmatismfix.com where you can enter if you have your preoperative values and decision, you can also enter it and you can see where the axis has gone wrong. And then some investigations such as Cirrus also shows for us to have a target plan, but the best will be the eye trace, which will show if there is a rotation problem. Repositioning, as I told, immediate, see in the slit lamp. If it is less than 10 degrees and on axis, you can try to leave it. If there is more than 20 degrees with a parallax error, definitely one has to rotate it immediately. So after 5 or 6, 1 week post-op, if you find that it is off axis, you should always wait for around 10-15 days, because that is where the bag is starting to get phimosed. So you don't know exactly whether that is going to be the final refraction or it might change. So what Dr. Ramesh has told before is 2 refraction to be done at the interval of 2 weeks apart and have a stable refraction. Once you see that every 2 weeks apart, 2 refractions are stable for spherical and cylinder, then you can plan according to your astigmatic fix or eye trace. And the time of rotation for ideally will be around 10 to 15 days. For some, when you try to rotate, always it is better you consider a CTR, because it will extend the bag and it will be easy for the lens to rotate, because the bag starts to get crumpled after a few days. So in late rotation and high myopes with big bags, always consider a capsular tension ring. With the innovations ahead, yes, we have the measurements from the swept source OCT. As I told you, the Cassia and the IOL Master 700, which shows accurate precision access for the patient. And the IOL calculation of ray tracing and the ORA and the HOLAS intro-op, they actually help in the aberrations and the aberrometer. And the guidance tools such as the True Guide, the Callisto, and the Virion are amazing devices to get a spot-on cylindrical toric lens. So I would like to thank the whole team once again. Thank you, sir.
Nishant, thank you so much, Nishant. That was a very wonderful and a very detailed presentation.